Good morning, everyone. Our topic for discussion for today is bone loss and patterns of bone destruction. So coming to introduction, bone that forms and supports the tooth is called the alveolar process. Destruction of this bone is responsible for tooth loss, and as the tooth is shed, this bone resolves ultimately. So the height and density of the alveolar bone are normally maintained by an equilibrium that is regulated by local and systemic influences between bone formation and bone resorption. When resorption exceeds formation, both bone height and density are reduced. Factors that cause destruction or the periodontal disease. There can be extension of gingival inflammation. Then it can be due to trauma from occlusion. It can also be due to systemic disorders. We will be discussing these topics later on as the slide continues. Bone destruction caused by extension of gingival inflammation. This is the most common cause. Now, as the inflammatory invasion of bone surfaces and the initial bone loss marks the transition from gingivitis to periodontitis. Periodontitis is always preceded by gingivitis, but not all gingivitis progress to periodontitis. So, gingivitis is basically inflammation of the gingiva. Till the time inflammation is only confined to the gingiva, till that time it is known as gingivitis. But once inflammation starts spreading, going apically, and there is loss of attachment, there is apical migration of junctional epithelium, then we say that gingivitis has finally progressed to periodontitis. Now, there can be extension of inflammation from marginal gingiva to supporting tissues. The transition from gingivitis to periodontitis is associated with changes in composition of bacterial plaque. In gingivitis, we usually have cocoid rods and straight rods, whereas in periodontitis, we have motile organisms and spirochetes. As far as cells are concerned, in gingivitis, there is predominance of plasma cells, and in periodontitis, there is predominance of polymorphonuclear leukocytes. Coming to histopathology, areas of inflammation extending from gingiva into suprabony area, coats along gingival bundle fibers, blood vessels, loosely arranged tissues, extension of inflammation into center of interdental cementum, cortical layer at top of cementum are destroyed and inflammation penetrates into the bony marrow. So this is the pathway from which gingivitis progresses to periodontitis. Pathways of spread of inflammation, facial and lingually gingiva to outer periosteum, periosteum to secondly it can be from periosteum to bone, and thirdly it can be from gingiva to pedial. Interproximally it can be from gingiva along the outer periosteum and from gingiva to the periodontal ligament. Now gingival inflammation, as it proceeds, it is replaced by leukocytes and fluid exudates, new blood vessels and proliferating fibroblasts. Then there is increase in osteoclasts and mononuclear cells, resorption of proceeds from within, thinning of bone trabeculae and enlargement of narrow spaces. And there is destruction of bone and reduction of bone height. And finally, there is replacement of fatty bone marrow with a fibrous type of bone marrow. Now, radius of action, this is very important, and it is seen that for a bacteria or for a toxin, it is not necessary that it should be in direct contact with the bone to cause bone resorption. It has been seen that there is a range of effectiveness, that is 1.5 to 2.5 mm, within which bacterial plaque can induce loss of bone. Beyond 2.5 mm, there is no effect. So interproximal angular defects or oblique defects can only occur in spaces where the distance is more than 2.5 mm. This is known as the radius of action. Now, rate of bone loss, it varies from individual to individual and also from site to site. On an average, in facial surfaces, it is found to be 0.2 mm per year, and on proximal surfaces, it is found to be 0.3 mm per year. Now, periods of destruction, it does not continues with a constant speed or in a constant phase. There are periods of destruction, periods of activity followed by periods of inactivity. So as the periodontal destruction occurs in episodic and intermittent manner, periods of inactivity and destruction, then this results in loss of collagen and alveolar bone, resulting in deepening of periodontal pockets. And this is followed by advanced force defense that controls the attack. And so there is a period of inactivity. Now, bone destruction occurs both due to bacterial and host-mediated reasons. So, bacteria they cause proliferation and differentiation of cells into osteoclasts, and they also inhibit the activity of osteoblasts. And whereas host-mediated, it causes a release of prostaglandin E2, interleukin alpha, interleukin beta, and human necrosis factor alpha. So then bone destruction caused by trauma from occlusion, periodontal response to external forces. Trauma from occlusion can occur in presence or absence of inflammation. In the absence, effects on alveolar bone ranges from resorption to necrosis. So trauma from occlusion is a very big separate topic, which will be discussed sometime later on. And when combined with inflammation, if there is both gingivitis, peritonitis, and trauma from occlusion is also occurring. For example, there is a high filling done by a dentist, and that is causing trauma. So then this area that has both trauma from occlusion and that is affected both by trauma from occlusion and inflammation is called as zone of co-destruction. Is plaque-induced inflammation entering into the zone of trauma results in angular bone defects. Then bone destruction caused by systemic disorders. This can be due to many diseases like osteoporosis, which causes loss of bone density, then osteopenia, hyperthyroidism, parathyroidism, and leukopenia. Fat is determining bone morphology in periodontal disease. It depends upon the trunk length and trunk width and the interdental bone dimensions. As I told you that angular defects can only form in where the interdental bone is more than 2.5 mm. So there are various reasons on which this depends the disease. Then exostoses are outgrowths of bone in varied shapes and sizes. They can occur in small nodules and sharp ridges, spike-like projections, or a combination of these. These are usually benign. The patient usually has no like problems with this thing. Then buttressing bone formation sometimes occurs in an attempt to buttress bony trabeculae weakened by the resorption. So this can occur both centrally and peripherally. If it occurs from the outside peripherally, it is also known as lipping. It can be due to food impaction also, due to this will results in inflammation and ultimately bone resorption. And in cases of aggressive periodontitis, we usually find vertical and angular bone defects. For example, in case of localized aggressive periodontitis, patient will present with an angular bone defect in the central incisors and uh, with an arc-like pattern of bone loss on the first molars. Then this is the main topic that we will be discussing. This is the patterns of bone loss. Now, bone loss can occur in various patterns. It can be horizontal, vertical. It can be in form of osseous craters or bulbous bony contour, reverse architectural ledges or furcations. So horizontal bone loss, this term is horizontal bone loss is said to occur when the pattern of bone loss, the plane of bone loss is at an angle of 90 degrees perpendicular to the long axis of the tooth. So this is the most common form of bone loss, and it is very tough to regenerate such loss of bone. As you can appreciate from the picture, the plane of bone loss is perpendicular to the long axis of the tooth. Then coming to vertical or angular defects, in this case, the plane of bone loss is not perpendicular to the long axis of the tooth. It is at an angle, it is oblique to the long axis of the tooth. So now these vertical or angular defects, also known as oblique defects, can be of various types. It can be one wall defects or two wall defects or three wall defects or combined osseous defects. So the like one wall defect means that there is only one wall remaining. It can be either facial or lingual or mesial or distal of the interdental bone. Only one wall is remaining. The rest of the three have been destroyed. In two wall defect, it means that two walls are remaining and two walls have been destroyed by the periodontal disease process. In three wall defect, it means that three walls are still intact, only one wall has been destroyed. And in combined defects, this is the most common type of that you see. In the coronal aspect, there are less number of walls remaining, and as at the apical part of the defect, there are more number of walls remaining. So for one wall, it is very like tough to regenerate a one wall defect or a very advanced two wall defect, and comparatively easier to regenerate or reconstruct a 3-wall defect or an initial 2-wall defect. You can reconstruct such defects with the help of garret tissue regeneration or bone grafts. So this is a very like proper diagrammatic representation of what I told you just, that the number of defects, number of walls, uh, how defects are classified. Now coming to osseous craters. In osseous craters, you have a like concavities at the crest of interintal septum. Only facial and lingual walls are present, whereas the mesial and distal walls are absent. So although you can detect it with the help of bone sounding, but it very hard to detect them on radiographs, routine radiographs, because there is overlapping of the facial and lingual bony plates on the radiograph, and you miss the concavities on the X-rays. So the reasons can be due to plaque accumulation and difficulty to clean normal concavity in lower molars and vascular pattern of from gingiva to crest, pathways of inflammation, as we have already discussed. Coming to bulbous bony contours, these are basically bony enlargements and adaptation to exostosis, adaptation to furcation or buttressing bone formation. They are more common in maxilla than in mandible. Reverse architecture, as the name suggests, normally the architecture is that the interdental bone is more cornal to the radicular bone, whereas you can very well appreciate from this picture that the radicular bone is more cornal to the interdental bone. There has been a loss of interdental bone, but the radicular bone is still intact. So this is known as reversed architecture. Ledges are plateau-like bony margins caused by a resorption of thickened bony plates. Now, furcation involvement. This is the involvement of bifurcation or trifurcation of multi-rooted teeth by the periodontal disease process. The most common mandibular molars, least common and maxillary premolar, because it has a very long root trunk length. So it has been classified by Carenza, by Glickman into grade 1, grade 2, grade 3, and grade 4. Grade 1 is basically there is incipient bone loss, and it is usually not detectable in the X-ray. There is only like you will find supra-bony pockets in this case. In grade 2 loss, the word that is used to describe grade 2 loss is basically cul-de-sac. That is the word that is used, and it is a dome-shaped pattern of bone loss. But the penetration of probe is not through and through. And in grade 3 bone loss, there is total bone loss at the crotch of furcation area, and but it is not exposed. You cannot see it clinically because soft tissue fills this crotch of the furcation area. Grade 4 is similar to grade 3, but due to gingival recession, the crotch of furcation is visible clinically. Conclusion: although periodontitis is an infectious disease of gingival tissues, changes that occur in the bone are crucial because destruction of bone is responsible for tooth loss. Bone loss patterns associated with periodontal disease is varied, and the type of management depends upon the type of loss. Thank you.